Okay, welcome back to the deep dive. We've got a really pretty intense topic today.
Yeah, this one comes from a listener, actually. Sent in a whole batch of sources, articles, accounts.
Right, and you asked us to dig into what happens when, well, when the drugs stop working.
Yeah.
Antibiotics, antifungals,
Yeah.
when resistance just gets too high.
hmm And the questions you raised were very specific, very real world. Like, how does this actually play out? What about doctors and nurses on the front lines?
Yeah, and people in crowded spots, apartments, barracks, how do they cope?
Ah.
And is there any way, based on this material, to spot infected people early?
Exactly. Big questions.
It's heavy stuff, definitely. But these sources really drive home that this isn't sci-fi. The miracle drugs are, well, they're failing in some cases.
They are.
So that's our job today. We're going to pull apart these sources you sent, see how they say we got here, what the threat really looks like now, and crucially, what this material suggests about dealing with the future of potentially untreatable bugs.
Okay, so where do we start? I think understanding the basics is key, right? The relationship between us and bacteria.
Yeah, we live with them. Trillions of them. Our microbiome, doing good stuff mostly.
Mostly, yeah. Digestion, fighting off bad guys. But then there are the ones that cause serious disease. Always been there.
And then antibiotics arrived.
Interesting that the sources point out they weren't, like, invented from scratch in a lab initially.
No, exactly. They came from nature. Fungi, other bacteria,
Yeah.
making these chemicals. The breakthrough was realizing they could kill harmful bacteria without, killing us.
Total game changer for medicine.
Oh, absolutely transformative. Think about surgery, chemo, transplants, all that stuff we take for granted. It became much, much safer. Possible even in some cases because we could handle the infections.
So the million-dollar question, if they were such miracle drugs, how did we end up here? With bacteria shrugging them off.
Well, that's resistance. And what these sources show is it's not like the bacteria waited for antibiotics. The potential was kind of already there.
Random mutations happen all the time in bacterial DNA. Or they can actually swap genes with each other. So a bacteria might just by chance pick up a gene that helps it survive a specific drug even before it's ever seen it.
So the capability could exist before we even start using the drug.
That's right. Bacteria multiply incredibly fast,
Yeah.
hours, not days. One becomes millions. So statistically, the sources suggest for pretty much any antibiotic we've ever used, there was probably already a bug somewhere with some mutation giving it an edge.
Okay. And then we started using antibiotics a lot.
And that's the selective pressure. It's a term that comes up again and again in this material. When you use an antibiotic, you kill off all the susceptible bacteria.
Leaving the resistant ones behind.
Exactly. They survive, they multiply, they take over the space. It's like accelerated evolution driven by us.
And it seems like people saw this coming way back.
Amazingly early. Alexander Fleming, penicillin.
Sure.
He warned about it in his Nobel speech, 1945. Yeah, he talked about not using enough penicillin, making microbes resistant. He worried about it becoming widely available and people misusing it. And another scientist, René Dubos, also raised red flags about overuse.
But despite those warnings, the sources map out this really predictable cycle. Depressingly predictable.
They do. New drug comes out, we use it, creates that pressure, resistance pops up, doctors start seeing infections they can't treat with it. Happened with penicillin, resistance went from like 8% to 60% in one hospital in just 5 years.
5 years.
Yeah. Tetracycline, introduced 53, resistance by 59. Chloramphenicol out in 58, resistance by 68. Vancomycin did better, held out for maybe 30 years.
And we try to get clever, right? Making slightly different versions.
Semi-synthetic ones, yeah. Like methicillin in 1959. Designed specifically to beat penicillin-resistant staph infections.
Oh.
Resistance to methicillin MRSA showed up within a year. A year. In the UK, 1960-61, the bacteria just found another way around it, and that pattern just kept repeating.
Okay, so resistance is sort of natural potential, but what did we do, according to these sources, that really kicked this into high gear, made it a crisis?
The sources are pretty blunt. A big one is overuse and misuse in humans. Doctors giving antibiotics for things they don't treat, like viruses, colds, flu.
Things they just don't work for.
Exactly. One source said maybe up to 36% of prescriptions for upper respiratory infections were unnecessary, just contributing to the problem.
And what about patients pushing for them? Or people just taking them on their own?
Yep, both mentioned. Patient pressure is real. And self-medicating, maybe with leftover pills or stuff bought without a prescription. That's flagged as a major issue, especially in some parts of the world, helping resistant strains spread globally.
Mhm.
There's also a point made about some doctors maybe relying too much on quick tests like dipsticks or just temperature instead of really digging into the patient's story, the whole picture.
So just exposing bacteria to these drugs unnecessarily, again and again,
Yeah.
training them almost.
Pretty much. And then there's the other massive factor the sources point to, agriculture.
Ah, yes, animals.
Huge use there. Not just treating sick animals, but routinely feeding them low doses of antibiotics to prevent disease in crowded farm conditions.
Okay.
And get this, to make them grow faster.
Seriously, growth promotion.
Yeah. One source traces it back to the late 1940s with chickens, got FDA approval in the early 50s, marketed for prevention too. Just adding it to feed became standard practice.
Wow. Has that stopped?
Some places have banned it, UK, EU, but the sources mentioned there was pushback, like in the US in the 70s, and the evidence presented here is pretty clear. All those antibiotics fed to animals contribute hugely to the resistance problem, and those resistant bacteria can spread to humans.
Okay, so overuse in people, massive use in animals. What else?
Even those everyday things. Antibacterial soaps, wipes, cleaners.
Right, they're everywhere.
The sources argue a lot of these products aren't strong enough to kill the really tough bugs, but they do kill off our friendly bacteria, which just clears the way for the resistant, unfriendly ones to move in. Sort of counterproductive marketing.
So all these things together, medicine, farming, household products, just creating this constant, intense pressure for bacteria to get tougher.
That's the picture painted here. And the scary outcome isn't just resistance to one drug anymore. It's bacteria figuring out how to resist lots of different drugs all at once.
MDR, multidrug resistance.
Right. There's an example of salmonella that started off resistant to a few drugs, then ended up resistant to basically all of them. Makes treatment incredibly difficult, sometimes impossible.
Which leads us right into the current situation these sources describe. These unstoppable bugs. It sounds like we're really facing infections that are effectively untreatable now, globally.
That's the stark reality presented. The sources give specific examples of organisms causing major concern right now. MRSA is probably the one most people have heard of.
Methicillin-resistant Staph aureus.
Yeah. Common cause of skin infections, but the sources track how it exploded. More ER visits, more hospitalizations in the U.S., spread out of hospitals into the community, and it can cause really nasty, life-threatening infections. Bloodstream, surgical sites, makes joint infections a nightmare to treat.
Are there others highlighted? Ones that are maybe less known but just as dangerous?
Oh, definitely. KPC is mentioned, Klebsiella pneumonia carbapenemase. These cause hospital outbreaks, very hard to stop, spreading beyond the ICU. Carbapenemase basically chews up carbapenems.
It's like last resort antibiotics.
Exactly. Losing those is a massive blow. Then there's NDM1, New Delhi metallobeta-lactamase 1. That's not a bug, it's a gene.
A gene?
Yeah, a piece of DNA that gives bacteria resistance to almost everything, including those carbapenems. And the really worrying thing, it's found everywhere, hospitals, environment, water, and it's described as promiscuous.
Meaning?
It jumps easily between different kinds of bacteria, spreads resistance like wildfire.
Wow. A mobile resistance gene? That sounds incredibly hard to track or contain.
It is. The sources also bring up things like XDRS typhi, extensively drug-resistant salmonella causing typhoid. There was a big outbreak in Pakistan described, resistant to all the standard treatments, linked to contaminated water. So again, spreading outside of hospitals.
And even malaria.
Yeah, the malaria parasite, Plasmodium falciparum, showing resistance, or at least partial resistance, to the main drugs we rely on now, ACTs. Seeing it in Southeast Asia, the Mediterranean, parts of Africa, makes treatment much trickier.
Okay, so this landscape, it brings us right back to your original questions about what happens when this escalates.
Yeah.
What do these sources say about the risks for doctors and nurses? Are they just expected to keep going in?
The sources definitely acknowledge the risk. They talk about the absolute need for PPC, personal protective equipment. Gloves, gowns, the right masks, face shields, and strict protocols for contact for airborne germs.
But the risk is still there.
Oh, yeah. One source mentions the Ebola outbreak in West Africa. Over half the healthcare workers who got infected died. It's a stark reminder of the danger with highly infectious, hard-to-treat diseases.
So, will they continue if things get really bad?
The sense you get from the material, especially one doctor's account, is, yes, there's this deep sense of duty, medical ethics, the drive to alleviate suffering. Dr. Fravatz's perspective is mentioned, commitment to care. even with risks, even without enough support sometimes. The implication is they will keep caring, adapting as best they can, even as the tools get weaker.
That's a heavy burden. What about the rest of us? People in crowded situations, apartments, schools, barracks. You asked about your own family in a small apartment.
Right. And this connects directly to how these resistant bugs spread. Contact, surfaces, contaminated water or food. It all gets amplified in crowded settings.
More people, more contact, more chances to spread.
Exactly. If someone's carrying a resistant bug, maybe without even obvious symptoms early on, the chances of it passing to others in close quarters are just much higher.
So those situations are high-risk zones.
Potentially, yes.
Yeah.
Significantly higher risk for rapid transmission, which leads to your question of what can families do, especially with vulnerable members in, say, a small apartment.
Yeah, what do the sources suggest?
Well, it comes down to prevention at the personal level. Education is stressed using masks when appropriate, really good hand hygiene, although they do note that some antibacterial soaps might not cut it against resistant strains.
Right.
Avoiding close contact with people who are sick. And a really important point from the sources. You can't just rely on the healthcare system, especially during big outbreaks. We saw with COVID-19 how systems get overwhelmed. Personal knowledge, preparedness, taking action yourself becomes critical.
That makes sense, being proactive. But you mentioned identifying people early is tough if symptoms are vague.
That's a huge challenge highlighted. Early signs of a superbug infection can look just like, well, like feeling run down. Weakness, cough, fever, headache, very nonspecific.
So how do you tell?
One perspective emphasized in the sources, Dr. Srivatsas again, is the importance of the story of the illness. Really listening to the patient, how symptoms develop, the context, not just relying on a quick temperature check or a single test result, especially early on. It's about clinical judgment.
Is there any mention of technology helping with that? Like for the public?
Yes, actually. One source talks about a concept like the Dr. Maya app. The idea is a tool to help you check your symptoms. Maybe using a simple color guard.
To see how serious it might be.
Right. To guide you on whether you need to isolate, if you should seek medical help, hopefully reducing unnecessary clinic visits where you could catch something else or spread something, and potentially, this is interesting, feeding anonymous data to public health units.
To track potential outbreaks early.
That seems to be the idea. A tool to help people differentiate minor stuff from serious illness and maybe streamline how we interact with the healthcare system, especially when it's stressed.
That's an interesting approach. Empowering people with information.
Fits the theme, doesn't it? Personal knowledge, using tools, whether it's good clinical skills or new tech, becomes more and more important.
Okay. So looking at this whole picture from the sources, the history, the causes, the current threats, the impact on people, and healthcare.
Yeah.
What are the proposed solutions? What can actually be done?
It's definitely presented as needing a multi-pronged approach. No silver bullet. A huge one is antimicrobial stewardship.
Meaning?
Basically getting way more careful and strict about how we use the antibiotics we still have, cutting out unnecessary use in humans, both in hospitals and by GPs, and drastically reducing use in agriculture and aquaculture. Strict programs.
Using our tools wisely. Got it.
Then prevention.
Yeah.
Vaccines are key. Sources mention vaccines for things like pneumococcal disease, typhoid, even flu. Because if you prevent the initial infection, bacterial or viral, you don't need the antibiotic later. Less use, less pressure.
Makes sense. But are we getting enough people vaccinated?
That's flagged as a challenge, yeah. Low coverage in some areas limits the impact.
What about new drugs? Are we developing replacements?
The pipeline is described as pretty dry, unfortunately, especially for truly new classes of antibiotics. It's slow, it's incredibly expensive, and let's face it, from a purely business perspective, it's risky.
Why risky?
Because resistance will likely emerge eventually for any new drug too, right? So its effective lifespan might be short. The sources mention that the usual market incentives aren't really working here, so people are exploring other ideas like government paying up front, subscription models for hospitals, funding accelerators, trying to boost innovation.
It sounds like this problem really cuts across different sectors.
Totally. And that's why the One Health approach gets mentioned. The idea that you have to manage this across human health, animal health, and the environment together. Global organizations like WHO are pushing this.
And technology, like that app idea, part of the mix.
The sources suggest it could be. Tools for symptom checking, guiding isolation, maybe linking to public health. They're seen as potentially valuable. And underlying a lot of this is education for the public, for patients. Knowing how to prevent infection, when to seek care, how to manage things yourself when possible, conquering fear through knowledge is a theme.
Okay. This has been, well, a very comprehensive look at some pretty challenging material. If you had to boil it down, based on these sources, what's the main message?
I think the clearest message is this isn't some far off maybe. Antimicrobial resistance is here, it's getting worse, and it's driven by a complex web of factors: how we practice medicine, how we raise food, how we live.
And there's no single fix.
Not even close. The sources point towards needing everything we've talked about. Using drugs way more responsibly, getting much better at diagnosis, using clinical skills and maybe new tech, pushing prevention hard with vaccines and hygiene, finding ways to develop new treatments, and really supporting our healthcare workers.
It is sobering, though. Thinking back to Fleming's warning in 1945, we knew on some level this could happen.
We did, and yet, as these sources lay out, the overuse continued, the problem grew.
Which leads to maybe the final, most provocative thought these sources leave us with, doesn't it?
I think so, given that we've known the risks for decades, and yet here we are. Can this escalating threat finally force the kind of profound global change in behavior across everything from farming to doctors prescribing habits to our own actions that's really needed? Or are we just going to keep getting outmaneuvered by microbes that adapt far faster than we change our ways?
A crucial question indeed. Lots to think about there. Thanks for walking us through all of that.